upcoming events. So this is for radiology fast track, which is for exam going students. This will be held in September from 20th to 22nd. And the idea here is to help students who are going for their MD, DNB, DMRE, or FRCR exams to prepare for these. We have an excellent team of teachers who will try to cover all the modalities in radiology. So we'll share the links for registration in the chat box. So please do make the most of it. Also, we have the online edition of the MRI teaching course coming up in November on the 16th, 17th, 23rd, and 24th. You can also register for the next MRI teaching course, which will be in Mumbai in April 2025. The registration is already open. A CT Buzz, which will be in Pune in October on the 5th and 6th, and Sonobuzz 2025, which will be again in Mumbai in Jain from 3rd to 5th. So let's move on to our session for today. It's my pleasure to introduce our speaker, Dr. Arati Joshi. She is a fetal medicine women's imaging specialist at Nanavati Max Super Speciality Hospital and PH Medical Center. She has more than 13 years of experience in the field of radiology. She is ISUOG certified. She's done an ISUOG certified course in fetal intervention. She's trained at Scholar MD and also done an advanced course in fetal radiology and genetics by MSBIRIA. She is co-authored of a chapter on fetal anomaly scan in the book Principles and Practices of Fetal Medicine. She has won several awards and presented in various national and international conferences. And it's a pleasure to have you here. Arti, over to you.
Hi, Dr. Gauri. Thank you so much for such a warm introduction. Good morning, everyone. And at the outset, I would like to thank Indian Radiologist and the Radiology Journal Club for starting this initiative and giving me an opportunity to be part of the same. I'm going to share my screen. The screen is shared, Dr. Gauri? Is it?
Yeah, it's visible. Yeah.
So today we are here to discuss upon the ISUOG updated practice guidelines for nuchal translucency scan, which were released recently in 2023. This is something which we do every day, the nuchal translucency. So let us go ahead and run through how to perform it with the updated guidelines. This is a little gist of how the session will be going on. First, we go ahead with the general considerations. And then we talk about the inner details. And towards the end, we will carry on with some of the cases which we saw at our institute in the first trimester anomalies and end it with the key learnings. So ISUOG, as we know, is a scientific organization which lays down guidelines for healthcare professionals to reflect what is considered the best practice at that time for diagnostic imaging. The general considerations are when and who can perform the scan. Now, this scan is performed between 11 to 14 weeks when the CRL is between 45 to 84 millimeters. Who can perform the first trimester ultrasound scan is healthcare professionals who have completed training in the use of diagnostic ultrasound and related safety issues, participate in continue medical education activities, who follow appropriate care pathways for suspected anomalies, and also regularly establish quality assurance programs. The equipment, the basic equipment with M mode, color Doppler, 2D ultrasound with TVS and transabdominal transducers are needed for this. Very important is the freeze frame and zoom capabilities with at least 0.1 millimeter advancement of electronic calipers. How do we store the documents? This is as per the local guidelines and protocols. In India, as per the PCPNDT, we are expected to store this for at least a minimum period of 2 years. Now, coming to the safety of the ultrasound in the first trimester, the B mode and M mode ultrasound is completely safe because of the low acoustic output. When it comes to Doppler ultrasound, because of the potential bioeffects when it is applied to a small region of interest in the embryonic period before 11 weeks, it is to be used wisely. However, between 11 to 14 weeks as well, we follow the ALARA principle, that is as low as reasonably achievable. So the thermal index should be kept less than 1 and the exposure time should be minimum between 5 to 10 minutes itself. When we are screening for the uterine arteries for preeclampsia screening, now the fetus is not in the field and hence it is safe. The purpose of the first trimester 11 to 14 week scan, these are the subheadings which we will be covering. So the purpose is to confirm viability, to establish gestational age accurately, determine the number of fetuses, whether it is single or multiple. If it is multiple, then to assess the chorionicity and amnionicity, to detect gross fetal anomalies, offer first trimester aneuploidy screening, and sixth is the preeclampsia screening. Now let's go ahead with each subheading. For assessing the viability, viability is defined by identification of the heartbeat, which we start seeing by around 5 to 6 weeks. And by 10 weeks, the heartbeat rises to about 170 beats and gradually decreases to 150 beats by 14 weeks. Now, this is important when the heartbeat is more than the 95th percentile. Particularly in trisomy 21, we see mild rise. In trisomy 13, there is substantial rise. And in trisomy 18, we see mildly reduced heartbeats. Then the confirmation of intrauterine pregnancy, that is the integrity of the uterus should be noted, whether it is appropriately placed, whether it is low placed closer to the cesarean scar, then this has to be closely followed for evolving placenta accreta spectrum, or if it is in one of the rudimentary horns of a bicornate uterus. So all this data has to be assessed. Coming to the second point, which we just spoke about, to establish the gestational age by fetal biometry. At this stage, the CRL and BPD are most accurate for establishing the gestational age. Now, for the CRL, the guideline says that the image should be zoomed such as it occupies most of the screen, and you measure it from the crown to the rump in a fetus being in a neutral position. And in the BPD plane, it can be done in two ways, either outer to inner or outer to outer. The other measurements which we do are similar to the second trimester, that is the abdominal circumference and measuring the femoral length at the diaphysis. Now, the CRL is an important measurement because that is used for the gestational age reference for your NT, the uterine artery PI, or the biochemical markers, that is the beta HCG in the PAPE. We should not try to normalize it as it may be reduced in fetuses with trisomy 18 and triploidy. So accurate measurement as per the guidelines, the best measurement should be used. Now, once we have established the dating and the EDD has been assigned either by ultrasound or by the menstrual age, the date should not be changed later in pregnancy. If the patient reports no menstrual dates, the ultrasound is the first in the first trimester should date the pregnancy. If there is a discrepancy between the ultrasound and the menstrual age by more than 7 days, then we use the ultrasound EDD. Now, why is this important? So once we have established the EDD, this can be used for assessing the follow-up growth scans and to detect either pre or post-term pregnancies. Now, coming to if it is, we need to see whether it is a single pregnancy or multiple pregnancy. If it is a multiple pregnancy, then this is a good time to assess the chorionicity and amnionicity. For this, two important signs are based on the thickness of the membrane. That is, in monochorionic twins, the membrane is thin and it attaches to the placenta, forming a T. So this will be a monochorionic diamniotic pregnancy. And when there is thick membrane and you see a twin peak or a lambda sign, it is diamniotic dichorionic pregnancy. If by transabdominal it is difficult, then we can use the transvaginal route at this stage. MCDA twins should be referred to tertiary center with expertise in their management. Now, how do we do the twin labeling? Twin labeling, you need to follow a consistent strategy. There are different ways of doing it. Either in one of the ways, like this is the transverse abdominal plane of the mother, and we can label the right fetus as twin A, the left is twin B. There is twin peak sign seen. Placenta of A is posterior, placenta of B is anterior, and hence this is a diamniotic dichorionic twin. The other way of doing it is labeling the upper fetus as B and the lower fetus closer to the os as fetus A. So the consistent strategy should be followed and need to be mentioned in the first trimester scan by doing appropriate labeling. The dating in 11 to 14 weeks of twin scan in spontaneous conception, the larger of the two CRL has to be considered to estimate the gestational age. After 14 weeks, the HC will be used. If there is discordance of more than 10% of CRL or more than 20% of the NT, or there is A wave reversal, then this has a poor prognosis and may cause early IODs or severe twin-to-twin transmission, particularly in monochorionic twins. In IVF pregnancy, the oocyte retrieval date or the embryonic age from fertilization is used for dating the pregnancy. After completing the dating, we are moving ahead with the fetal anatomy. Now, for the fetal anatomy, ISUOG has laid down two specific criteria. One is the minimum requirements and other is the detailed examination. So this purely depends which one we follow based on the type of machine available at our disposal and on the skill of the healthcare professional. So looking at the minimum requirement, quickly we run through, that is measuring the CRL, then the BPD, then in the head, we are also seeing the butterfly sign, wherein the lateral ventricles are being filled by the choroid plexus. Moving on to the neck, the NT is measured with the guidelines, which I will be discussing shortly. In the abdomen, we look for the two cystic spaces, that is the stomach and the stomach and the urinary bladder. And in the chest, the heart with the four-chamber and the regular rhythm to be noted. The extremities, the three segments of both the extremities, and look at the placenta, any cystic spaces, without any cystic spaces. So this completes your minimum criteria. Moving on to the advanced parameters. So in this, I'm going to go ahead stepwise. So in the head and the brain, we've already discussed the minimum one. In the detailed examination, you're expected to look at the aqueductus sylvius, the cerebral peduncles, and a little below in the transcerebellar plane, you're going to see the IT or the fourth ventricle communicating with the future cisterna magna. Also, the mid-sagittal view, which we use for the nuchal translucency, is very useful. Here we are going to see the three lucencies. This is the diencephalon, this is your brainstem. Just beneath that would be the fourth ventricle with the choroid plexus. And then this is the cisterna magna. So normally the brainstem to brainstem occipital bone ratio is less than 1. However, when there will be any neural tube defect, there is obliteration of cisterna magna and the BSOB reduces. So the brainstem to brainstem occipital bone ratio will be more than 1. Also, this plane is useful to identify any posterior fossa cysts. After completing the head, we move on to the face and the neck. Neck again, after looking at the NT, these are the additional things in the detailed examination, that is look for the orbits, look for the maxillary process, the premaxillary triangle to look for any facial bony clefts, then the normal mandibular gap. And in the thorax and the heart seen at an axis of about 30 to 60 degrees and the echogenic lung seen around them. Then at this stage, we are expected to use color Doppler so that we can assess the four-chamber view and the outflow views. This will help us identify early cardiac abnormalities, which are normally associated with also chromosomal anomalies. Moving on to the abdomen, again, apart from the two cystic spaces in the detailed examination, we are expected to see the two umbilical arteries across the urinary bladder and the kidneys, which are seen alongside the spine. Now, these details are much better appreciated on a transvaginal scan. Looking for the intact abdominal wall. As we all know that there is physiological gut herniation, which is seen just around up to 11 weeks. And later on, if you see, it is called as omphalocele. However, the criteria for this is if it is between 4 to 7 then it is physiological gut herniation in the early stage. Anything beyond that, even in the early stage, is to be suspected as evolving omphalocele. Coming to the extremities, we look for the three segments of the extremities of both the hands and the feet should be documented at this stage. And in the detailed examination, we also expected to observe the movement of the limbs. Then in the spine in the sagittal and the coronal plane, and to look for the continuity of the skin overlying to observe for any open neural tube defects. Now, once we have completed the anatomy, we move on to the aneuploidy screening. So the nuchal translucency, the most important parameter for which we do the scan, what is it? It is a sonographic appearance of collection of fluid under the skin behind the fetal neck in the first trimester. Now, this is increased in chromosomal abnormalities, cardiac defects, and genetic syndromes. There are various guidelines laid down, and the one which commonly is also being followed across is laid down by the FMF UK, that is the Fetal Medical Foundation, in which we are expected to measure it such that the fetus is in a neutral position. The image is zoomed sufficiently that it occupies the head, and the thorax should occupy most of the screen. And you should be able to demonstrate it in a neutral position and to be able to see the NT separate from the amnion. The calipers should be such that up to 0.1 increments should be seen, and the placement of the calipers is also crucial at this stage. It should be placed inside the lucency, that is, it should be on to on and not outside or on the inner aspect. So the C is the correct method of measuring it. Now, once we have measured the nuchal translucency, we have nomograms available, which tells us where it falls, which percentile. But the general rule is more than 3.5 millimeter at any CRL is abnormal. Now, this we do every day, and there are a lot of pitfalls and troubles we go ahead. Like this is one of the fetuses. Now, this sort of a measurement would be wrong. Why? Because the NT and amnion, you're not able to separate the two. It is not zoomed. The fetus neck is flexed. In this image, again, the fetus neck is little flexed, and this is not the mid-sagittal view. You can see the maxilla. This again, you're not even able to see the nasal bone, and it is a parasagittal. So these are the wrong views. Now, why is so much fuss made about the NT? Just look at it with an example. This was a 30-year-old primigravida who came for us with an NT scan, which was done elsewhere for a second opinion, saying that it is a thick NT. So when we started off the scan, this was almost around 13 weeks. So we got an NT of around 3.3. But do you think this is appropriate? No, the fetus is not in the neutral position. Though it is a mid-sagittal, it is not a neutral. So it came to be 3.3. After some time, the head was extended and it was 2.4. So we made the patient wait, walk around, come back in some time and look at this. Now the fetus is giving us the appropriate position and in the neutral position, mid-sagittal, after following all the guidelines, the fetus, the NT is 1.6. So directly from 3.3, which was close to the 99th centile, the NT falls into 1.6, which is around 50th centile. So this NT measurement will be taken and used in your serum biometry parameters, and the combined risk will be given. So one wrong measurement can directly put the mother and the fetus into a high risk category, whereas once we measure it appropriately, we know the true risk of the fetus. That is the importance of the guidelines here. Now, the other pitfalls are sometimes you may see multiple lines beneath and you don't know which one to measure. So, patience is the key. Once the baby moves, you will be able to differentiate the amnion from the NT and you know that which parameter we are supposed to measure. The second way is to use the color Doppler. Sometimes you may be able to see an umbilical cord behind the nuchal translucency, which may falsely be increased. In such a situation, we measure the NT, which is below and above, and use the mean of it. Moving to the other parameters, now apart from the NT, the other advanced markers are nasal bone, ductus venosus, and tricuspid regurgitation. So nasal bone, again, the parameters are similar, the mid-sagittal view, which we have already discussed. Apart from this, you need to see three distinct lines. The top line represents the skin, the bottom line and the thicker and more echogenic is the nasal bone, and this is the nasal tip. So this is the appropriate parameter where you will be measuring it. When it is absent or hypoplastic, that is when you are seeing it less echogenic or not able to appreciate it, then it is a marker for trisomy 21. Now, ductus venosus. What is ductus venosus? The oxygenated blood from the placenta is carried through the umbilical vein and is taken into the heart via this special trumpet-shaped vessel. So the high velocity oxygenated blood will go directly from the right atrium into the foramen ovale and to the left side of the heart. Thus, highly oxygenated blood will reach the fetus. So it plays an important role. The measurement of ductus venosus is important. It is to be done such that the image is again magnified in the ventral mid-sagittal view. The gauge should be 0.5 to 1 mm with a low filter of 50 Hz and sweep speed of 2 centimeters so that we can appreciate the waveforms better. Recent studies show that increase in ductus venosus PI is associated with increased risk of trisomies. So it is a good practice to start measuring the PI, the nomograms for which are available. When we start seeing the A wave reversal, again, it is a marker for aneuploidies or evolving cardiac abnormalities. Now coming to the next parameter, which is the tricuspid flow. How do we measure the tricuspid flow? That is, the four-chamber view should be zoomed enough that it occupies the screen. The gate is placed across the tricuspid valve. It should be 2 to 3 millimeters. Again, the angle should be about 30 degrees. And this is a normal tricuspid valve. When you start seeing the flow in reverse, it's called tricuspid regurgitation, and more than 60 centimeter per second for more than 50% of the cycle is recorded as regurgitation. Less than that can be normal because of the surrounding aortic or the pulmonary valve flow, which you may get mixed along with this. Now, after this, we go ahead to the serum biochemistry. So prior to the aneuploidy screening, it's important to do the pre-test counseling. That is, the couple should know that these are screening tests and the difference between a screening and diagnostic test. So once we get a combined risk, then that does not mean that the fetus is abnormal. It means that it's a high risk for abnormality and needs a diagnostic testing in the form of CVS or amniocentesis. So for serum biochemistry, quickly let me run through. As we know, beta-HCG and PAPE are used in the dual marker. Now, an easy way to remember the moms would be, in euploid fetuses, both beta-HCG and PAPE are 1. In Down syndrome, the beta-HCG is raised to 2 and the PAPE is half, almost 0.5. Okay, in the other trisomy 18 and 13, they are less than 1. And in diandric fetuses, the beta-HCG would be markedly raised, that is 9. So this is a quick way to kind of remember. Of course, you have nomograms always available for reference. Again, in the NT, in trisomy 21, the NT is about just marginally raised 3.5 around. And in trisomy 13 and 18, you're going to see it up to around 4 and 5.5. For Turner syndrome, it's generally more than 8. So once we have all the data, the FMF also has these calculators which are available freely, and we can use all the data and give a risk. Once the assessment of risk is done, we have to put them into high, intermediate, and low risk. The high risk group, which is more than 1 in 50, has to go in for diagnostic invasive testing in the form of CVS. Intermediate risk, we can use the new markers, that is the NT, ductus, tricuspid, put them into, again, more risk more than 100, then goes for CVS less than 100. put in the low risk group, and sonography at 20 weeks. That is the anomaly scan is to be done. With the advent of NIPT, also a lot of intermediate risk groups are subjected to NIPT, which gives a very high detection rate and a low false negative rate, which is almost up to around 99 to 100%. Sorry. So screening in twins, how is it different? In monochorionic twins, we have to average of the both because they share the same karyotype. In dichorionic twin, it is calculated as per fetus. Now moving on to the preeclampsia screening. How will you measure the uterine arteries? Visualize the cervix and sagittal view. Activate the Doppler. Tilt the transducer to right and left parasagittal plane to identify the uterine artery as it crosses the hypogastric vessels. Pulse Doppler, again, gauge should be around 2 mm, angle less than 30 degrees. And the mean of 2 to 3 values to be taken for each artery. And the risk is calculated based on the maternal age and risk factors, mean arterial pressure, uterine artery PI, and PLGF. Again, the FMF has calculators for the same, which we can use. The high-risk group is the use of aspirin is subjected for them, 150 milligram per day at bedtime from 12 to 36 weeks. This is known to reduce the risk of preterm preeclampsia by about 60% as per the NICE group and aspirate trials. The low risk group is reassured and again reassessed at 22 weeks. Now, once we have done the anatomy, aneuploidy, now we go ahead with the intra and extrauterine pathologies. Uterine anomalies like septate, bicornate uterus. If it is on one side, then you need to mention it at this time. Look for any cystic spaces, subchorionic collections, which are more than 5 centimeters in the placenta, need to be followed. If there are any large myomas in relation to the fetus, you mention the location and the size, monitor them for the same. Ovarian adnexal pathologies like cysts need to be watched out for through the pregnancy. This is a good checklist which is given by the ISUOG, which you can assess along with this article. On the basic examination, just we discussed, and the detailed first trimester examination. Now let's have a look at the anomalies in the first trimester. The ones which are identifiable easily at this stage are cystic hygroma, anencephaly, body stalk anomaly, megacystis, and large omphalocele, to name a few. Potentially identifiable are the spina bifida, the open spina bifida. We just discussed the BSOB ratios. Posterior fossa cyst, increased NT with major cardiac abnormality. The ones which we cannot detect at this stage are agenesis of corpus callosum, congenital cystic adenomatoid malformation, bowel obstruction, cerebellar hypoplasia, and microcephaly, to name a few. Now, we are also going to quickly discuss few of the cases which we had at our institute at the NT time when the fetus and the mother has come for screening. Let's look at the first case. She's a 36-year-old lady with a bad obstetric history. She had 3 miscarriages. At the NT scan, what do we see here? There is evidence of significant nuchal thickening and edema along with septate. There is also subcutaneous edema. When you see closely, there is evidence of pleural effusion. Nasal bone is absent. So this all points towards, this is a 3D image of the same, which helps us to see things better. So putting everything together, this was a high possibility for chromosomal abnormalities, particularly trisomy 21, Turner syndrome, trisomy 18, and Noonan syndrome. So such fetuses should be subjected to karyotyping, and also it may be, if the karyotype is normal, it may still be indicative of cardiac abnormalities, disturbances in lymphatic system, infection, metabolic and hematological disorders. Rarely, the cystic hygroma may resolve by 16 weeks. So if everything is normal, a close follow-up at 16 weeks, and then again, 20 weeks anomaly and 24 weeks for fetal echo should be performed. In this case, however, it was a very thick NT and the cardiac activity was not there and has a poor prognosis, and this was an IUD. We lost the patient to follow up. This is a second case. It's a 43-year-old primary gravida who came for NT scan. What do we see here? This is a thickened NT of around 6.1 millimeters at around 12 weeks. When we did the systematic anatomic survey, as we have just shown, the heart, when you see the cardiac, just see here, the crux is absent. So when we use the color in the spectrum, there is a regurgitation across the tricuspid valve, and this is definitely more than 60. Yes, this is 120 centimeters per second. The ductus venosus was showing an A wave reversal. Now again, we are looking at the skeletal system. This is the normal expected, wherein we see the 3 segments. But however, in this fetus, see what you're seeing. There's the humerus is seen, but in the forearm, only one bone, which is the ulna. The radius is not seen. There was a fixed angular deformity at the wrist, less movements seen. So putting everything together, thick anti-cystic hygroma, there was absent nasal bone, AVSD with A wave reversal, tricuspid regurgitation, and absent radius. So this is proposed to be a trisomy 18 with radial ray defect, and this was confirmed on further testing as well. So what is radial ray defect? It is a rare spectrum of malformation. It may be either unilateral or bilateral. There may be partial or complete absence of the radius and the radial carpal bones or thumb. This is associated with trisomies, as we have just seen. Other association are teratogen exposure like valproate, thalidomide, some syndromes like Vactorel, Holt oram, thrombocytopenia, absent radius syndrome, to name a few. Coming to the next case, this was a 39-year-old primate who came for NT scan. So when we measured the NT, the NT looks normal. This was around 1.4 mm. But look at the nasal bone. Do you remember the slides that we did before, wherein it is said that the nasal skin and the nasal bone should be more thicker and echogenic. However, here, how is it seen? It is barely seen, less echogenic and smaller. Even in the coronal plane, where we check the PMT and the maxillary mandibular gap, the nasal bone is, sorry for my voice, the nasal bone is not well appreciated. So this came out positive for Down syndrome. So what is Down syndrome? It's a common chromosomal abnormality. Now the mean NT is about 3.4 mm. Absent or hypoplastic nasal bone is seen in about 50 to 60% of fetuses, and it can be used as an additional marker to improve the efficacy. Beta HCG, as we have discussed, will be high with an MOM of around 2. PAPA will be low, around MOM of 0.5. There can be ductus venosus A wave reversal, ductus agenesis with it draining into the IVC, tricuspid regurgitation, cardiac anomalies like EIF, AVSD, and TOF can be seen. Pilectasis can be seen at this stage. Another interesting case where 35-year-old female came for NT scan. What do we have here? As you can see, there is absence of cranial vault. The amorphous brain parenchyma is seen in connection with the amniotic cavity. There is also facial dysmorphism. You can appreciate the Mickey Mouse sign, which is described in literature. So this was acrania, exencephaly, and encephaly sequence with a high mortality, and it is universally lethal. It has a prevalence of 1 in 1,000 births. The CRL will be often smaller. Aneuploidy rates are increased along with triploidies. There may be association with spina bifida, anencephaly, cardiac, and other facial abnormalities. Then this is the last case. So a 33-year-old primate for NT scan. And what do we have here? There's a large thoracoabdominal wall defect. You can see the liver and the bowel loops freely floating in the amniotic cavity. Also, there's a defect in the anterior sternum. And the heart is seen outside, that is ectopia cordis. So when we put everything together, This comes into pentalogy of Cantrell. Intracardiac abnormalities like tetralogy of Fallows may be commonly associated with this. There may be a wide spectrum of pentology, and the prognosis depends on the size of the wall defect and the type of cardiac malformation. Along with this, there were other associated findings like a short cord. You can appreciate in the sagittal view, there is a cleft palate as well. With the use of 3D, 4D, we can see the multiple abnormalities together with the bowel, the liver floating outside, the ectopia cordis. There's also kyphoscoliosis. There was CTEV. So this was useful also to explain to the parents the gross abnormalities, and after counseling with the geneticist and the treating obstetrician, finally the patient decided to not to continue the pregnancy, and the karyotype, however, was normal in this case. This is a beautiful article in the American Journal of Radiology, which has an algorithmical approach to how to determine the abnormalities. So I'll just quickly run through, but if you find time, please go through this article. So when the defect is seen to the right of the umbilical cord, it is gastrogenesis. When the defect is seen below, it is cloacal extrophy, bladder extrophy, or OIES. When the defect is seen above, as in our case, it is pentology of Cantrell. Then when the cord inserts onto the defect, it is an omphalocele. When there is no definite pattern, it could be a amniotic band syndrome. When there is paramedian cord insertion with a short cord or overall absent cord, along with limb defect, facial defects, it can be a body stalk anomaly. And when there's a predominant limb defect, it will be limb body wall complex. So again, to run through, please follow the systematic approach, whether you are able to do the minimum requirements or the detailed first trimester. Use of checklist can make things very easy, and a systematic approach can be followed. So what are the key learnings? This nuchal translucency scan or 11 to 14 week scan is a very important time to do the dating. Along with that, aneuploidy screening can be done. So if we are using the maternal age, the NT, nasal bone, ductus and tricuspid, along with biochemistry, the detection rate increases to almost 96 to 98%. However, with the use of cell-free DNA and NIPT, this is slowly going to go obsolete. So why would we be doing the NT scan then? Because it still is needed to do for the detecting early structural abnormalities and for preeclampsia screening. So are we moving towards an NT scan becoming the new anomaly scan? The future only knows that, but I think we are heading there. So please start practicing the 4-chamber view and outflow views in color. This will not only help us to identify, but raise suspicion for evolving cardiac abnormalities. The intracranial lucency, already we are doing if we are doing a proper NT image, we are getting in the mid-sagittal view. Look for the lucencies, look for the IT. This will give us an idea towards evolving open neural tube defects and spinal abnormalities. And preeclampsia screening in our country, the major problem is IUGR. So preeclampsia screening at this stage is very crucial. Once we start the mother with early aspirin, we are paving way for the healthy babies and a healthy future. These are my references. Thank you so much for your patient hearing. And I would just like to end it by saying the eyes don't see what the mind doesn't know. So it's a learning experience for all of us. Thank you so much. Thanks, Indian Radiologist, for this opportunity, and thanks for a patient hearing.
Thank you so much, Dr. Arti, for that excellent article discussion. Currently, there are no questions in the chat box, but maybe if you can just type in your email ID, then people can always reach out to you in case they have any queries.
Sure. Thank you so much, Dr. Tavri.
All these videos are available on the YouTube channel of Indian Radiologist. You're already getting positive comments from the delegates. So it's really very nicely discussed, and also the cases.
Thank you, thank you. But this is something which we do every day, and there are so many challenges we face. And I thought that this would be useful for us to know what are the new guidelines and how we can implement this, probably from just the coming Monday, and share things with each other. Thank you so much, and
Well,
have a great weekend.
so we've shared the link, the PDF, in fact, for the ISWOG guidelines on the chat box. You all can download it. You can always visit their website, which is ISUOG.org. There are a lot of other articles and guidelines available as well, so you all can always go through that. And we hope to cover few of those in our future journal clubs as well. So thank you everyone once again, and thank you, Aarti. So I think we'll see you all next month with
Thank you
another.
so much. Yeah.
Yeah, thank you.